So this is a left tympanoplasty for what you can see is a really atrophic tympanic membrane with perforation here and a thick cartilage plate which is there. This perforation was made because I was dissecting the posterior half of the tympanic membrane. So of course it's so atrophic that I had to remove part of the tympanic membrane here, but doesn't change anything because I decided of course to do a tympanic membrane grafting. So I already did an incision from 12 o'clock to 8 o'clock. This is, as I said, the left ear, though this is 12 o'clock, 3 o'clock, 6 and 9 o'clock. You can see the Malleus handle here, the chordae tympani. I'm going to show you this. So I'm already elevated the posterior half of the tympanic membrane, as you can see. So this is the chordae tympani. And what we have is an eroded incus with a connection with fibrous tissue, fibrous band connected to the stapes head. So this is the stapes here, which is mobile. You can see the facial nerve on the right, so I can see the fallopian canal, and we have a nice vision and exposure of the footplate here. So this stapes is mobile, so we have to do ossiculoplasty. But also I have to sacrifice this cartilage here, which means that I need to remove part of the tympanic membrane, enlarging the tympanic membrane perforation. So I will do that now, because otherwise if I leave it, I won't be able to put a graft in a nice position. So I need to remove this thick tympanosclerotic plaque, which is also connected, by the way, to the Malleus handle. Very interesting to see that. You can see this tympanosclerosis, which is there, quite thick, underneath the Malleus handle. Calmez encore, s'il vous plaît. So I will have to remove that anyway. But first, I just want to remove this huge tympanosclerotic plaque. Ciseaux. If it's a really thin one, then I don't need to remove it. I leave it and I put the graft underneath. But of course, if it's too thick like this, I cannot put the graft, so I need to remove it. Okay, that's really thick. Okay, c'est bouché. Okay, so I'm going to remove the tympanosclerotic plaque. And then I'll probably have to increase the incision and to elevate more the flap, ciseaux. You can see this fibrous connections to the stapes head. So I'll remove that now. Okay. All right. So I'm going to check now the inferior part of the flap to see if I have a clear exposure, because of course I will have to take a graft from the tracheal superior column graft, and I will place the graft over the bone. Okay, that's fine. We can see the annulus here. I think it's going to be enough for me to be able to place the graft over the bony canal wall. Calmez, s'il vous plaît. Ou plutôt décolore encore, s'il vous plaît. I have to enlarge a little bit, elevate the section here of the flap. And now I think it's fine. Calmez. Now I can elevate the annulus from here. Okay, I think it's going to be enough. Yeah, definitely yes. Okay, so what I will do now, I will stop the recording while I'm going to take the pericardium graft from the tragus and prepare the graft, and then we will come back for the ossiculoplasty and then the tympanic membrane grafting. So this is the tragus, and I'm going to infiltrate now the tragus here with a mixture of oxalocan and adrenaline, mainly adrenaline of course, in order to help for finding the cleavage plane. I will dissect the cartilage, and I'm not going to take the cartilage, I just take the perichondrium. So I make an incision like this, and I will now try to elevate a flap from, not a flap, a graft from the posterior part of the tragus, which means the medial side of the tragus. So you see here the cartilage. So I'm not going to take the cartilage. I'll leave the cartilage and I just dissect here the tragus. There we go. I think it's going to be enough. It's quite a nice one, I think. All right, that's going to be fine. So I'm going to use now the knife. So I'm now making the incision through the perichondrium, trying to preserve the cartilage right underneath. So I'm going to find the cleavage plane between the perichondrium here and the cartilage. So I think we have it here. And now we need to elevate this perichondrium flap. It's still connected to the cartilage, but it's coming progressively. So I'm using this knife, this nice instrument, which is not a knife, but just an elevator, smoothed one. So I'm holding the graft with crocodile with my left hand, and then dissecting this perichondrium. You can see the cartilage here. Okay, I think it's going to be enough. And of course, if I have a larger perforation, then I would take both sides of the perichondrium, of the tragus, I mean. Okay, I think it's going to be fine. And this one too. All right, so it's a nice one. So I'm going to put it on the press and leave it in the press until the end of the, not the end, but the time I will have to put the graft. So this is the press. Theoretically, we have two sides of the perichondrium. This is the medial side, which should be more sticky than the lateral one. Okay. It's fine, so we'll come back for the... So I took the graft, everything is prepared, and now we're going to start with the dissection of the malleus handle, because of course I still want to do the malleus relocation. This is some still mucosa of the middle, which I don't want to suck, and the chordae tympani is fine. So I'm going to now dissect the malleus handle. Calmez manger marteau. See that the sucker is stick to any fibrous tissue that we have. I don't suck directly to the chorda, but the mucosa is just connected to the chordae tympani. Okay, so I'm trying to perform this to elevate this periosseal flap, trying to preserve as much as I can the residual tympanic membrane. Although it's quite atrophic, I don't have such a large graft that I would reinforce the whole tympanic membrane, so I will dissect and try to preserve the residual tympanic membrane and just reinforce the posterior and inferior central part of the tympanic membrane. So now I'm just at the level of the umbo. There is no residual incus, or I mean the incus is totally eroded. As you can see, I can't find any incus there. Ciseaux. So I try not to suck directly to the tympanic membrane also for the same reasons, pre-atrophic. Ciseaux, s'il vous plaît. Okay, that's it. Calmement du marteau. And I think I need to go anterior to the malleus handle, and I think it's gonna be fine. Here we go. We have a little bit of tympanosclerosis, but here doesn't change the problem. Ciseaux. Alright, and now just the superior part of the malleus handle. Do it very gently, as you can see, because it's very fragile. Calmement, je marche encore. So you see the trick, I'm holding the malleus handle with the sucker, which is placed anterior to the malleus, and pushing a little the malleus handle. So it makes some resistance. Now it's fine. It's okay, but let me check the tympanic membrane to see if there is a larger perforation or not. Yeah, a little bit larger, but it's fine. Good enough, because it's not anterior, so it's still easy to close. So this is fine. I have some residual tympanosclerosis here. Maybe I can try to cut it and remove it. Ciseaux. Yeah, I think it's gonna be easy to do it and fine. Okay, now it's much better. Okay, so now what I'm gonna do, I will re-elevate the flap, and I will put the I will relocate the malleus posteriorly. Before placing the graft, I just want to place the malleus in a better position. And of course, I will use a TORP with silastic bending. On peut préparer la TORP avec silastique. All right, so let's cut the tympanic tendon out. On CV direct. There's no residual incus. You can see that total erosion of the incus. Probably some residual body of the incus, but not the long process is not that anymore. So I'm going to hold now the malleus handle and then pull the malleus. I put the sucker again on the other side to just control the mobilization of the malleus. And you see now the anterior tympanomalleolar ligament has been completely overstretched. You could see the movement. And now let me measure the distance before placing the graft. But before that, I need to stick the malleus back to the tympanic membrane first, to be sure that I will measure from the good position, the correct position of the malleus handle, which is not completely the case here. You see it's a little bit medialized. So I will pull a little bit of malleus up to lateralize a little bit more the malleus handle. And I think this is going to be fine. And now I can definitely measure the distance from malleus to footplate, because I intend to use a TORP and not a PORP, as you know. But of course PORP will be fine also. There's no much difference in terms of precision, but I always use TORP myself. That's my personal view. But all type of reconstruction, including incus transposition, if the incus was there, could be possible, of course, there. So I'm measuring now the distance, which is, this is 6 millimeter is in front, which means 6.5 will be good enough. All right. Now I need to cut the stapes tendon, because I will use it to, you know, hold the silastic band, which is done now. And now I will put the graft. I will put the ossiculoplasty. I will do the ossiculoplasty only at the end. Long, s'il vous plaît. Okay, so let's push the or elevate more the flap. You can see how much with the sucker, with this mucosa, it's holding the cord tympani, which should be a little bit more dry, I think, but it's not going to be an issue, I think. Alright, so let's put the graft now. So I just have to reinforce at least the posterior half of the tympanic membrane. That's what I need, and especially because of course the prosthesis will be at this place. So right underneath the graft, I use, as usual, hydroxylapatite head prosthesis, but it's always better in this case to reinforce the tympanic membrane, which is not good enough for just leaving the head right in contact with the tympanic membrane. So I'm holding it with a sucker, trying to place the graft over the malleus-handle like this. So this is again why I like to have both hands free, because I just hold the vein with the graft with the sucker, and I use my right hand with a needle to stretch the graft. I just want to place it perfectly, so I like to stretch it to be sure that I'm covering widely this posterior half of the drum, which I think is going to be fine. I will put the left part of the graft over the bony canal wall now inferiorly, and of course the malleus-handle will also hold the graft because the graft is over the malleus-handle. Okay, it's quite a large one, as you can see, so I'm stretching it like this, and now I need to be sure that the graft will be fine. So of course I need to reposition the tympanomeatrial flap and work a little bit to be sure that I'm covering completely the whole perforation which was there, as you remember. So it looks really fine. I'm just holding the skin a little bit to be sure that I'm placing it over the graft, and it looks really good. So I think it's gonna be fine. Okay, so now I will of course elevate the flap and do the ossiculoplasty with the prosthesis. Okay, let's like this at the core tympani again. It's not that dry, which is good. Now of course I need to take back the malleus-handle. You see the graft here, and the malleus-handle is overlying the stabilizer. Table vers moi, s'il vous plaît. All right, so it's time for the ossiculoplasty now. Vers moi. Stop. Tête en déclive encore un peu, s'il vous plaît. Stop. And 12. We have a nice exposure of the stapes and the footplate. I will remove a little bit of the blood to have a better exposure and a better view. Right here and also right here. You can see the footplate here in the middle. Okay, so now everything's ready for the prosthesis. So I'm going to cut it at 6.5. So remember we measured 6.5. And with this type of prosthesis, I need to cut it at 5.5 first and then pull it back at 6.5 because of the proximal part of the shaft which is going through the prosthesis head. So that 5.5, and then I will, when I pull backwards, it will come up to 6.5. And now you can see, of course, we have this silastic band right in the middle of the shaft, and you can see 6.5 pass. Alright, so I think I need to push a little bit the silastic band a little bit lower. I think one more. Okay, now I think it's gonna be fine. Okay, so I need to place the prosthesis first, placing the shaft right to the footplate. So I will use the sucker to do that, to introduce the prosthesis. And I just need to first place the flap, the shaft. That's what I need to do. Okay. Calmez. So I'm going to hold again the prosthesis with my left hand and the sucker, and I will drive the shaft with my right hand because it's not in good position here still. I like to place it right in the middle of the footplate. And again, this quarter tympani is coming up in the middle of the field, as you can see. It's making trouble to drive the prosthesis correctly. Okay, now it's fine. And now what I'm going to do, I will place the malleus within the groove of the prosthesis head. Crochet, s'il vous plaît. So I need to hold the prosthesis and then pull the malleus like this in 2 steps. I think I need 2 steps to do it, can I? And I think it's going to be fine if I rotate a little bit the prosthesis head like this and push it anteriorly. It should go into the groove. Yeah, it's doing well. Okay, I think it's fine. And the last step, of course, is to attach the prosthesis to the stapes with the band, and it's gonna be okay. So that's the tricky part of the technique, of course. I know that's probably by doing this I will dislocate temporarily the prosthesis from the stapes footplate, but it doesn't matter. I will reposition it later on. There we go. We have a little bit of a mucosa on top of the head. That's it, and right underneath the tendon here. And now I need to work a little bit with the prosthesis to place it perfectly, because I'm not happy with the position of the distal tip of the shaft. It needs to be central like this, and now it's fine. You can see if I move the prosthesis, they're moving together just like a single unit with the stapes, so it's gonna be fine, and the malleus is fine too, and we have a final vertical position of the prosthesis, so it looks really nice. But of course I need to check everything, so I will reposition now the flap and see if everything goes well with the tympanic membrane and the graft, of course. But it seems to be good. I need to check that. Un œuf, s'il vous plaît. Okay, so we have a little bit of a blood here, which I need to remove just to check the position of the graft. So atrophic tympanic membrane. It's very. It looks good. Everything is fine. Ciso. I think I removed that because it's some kind of residual tympanosclerosis also. So I don't want to leave it. And now it's fine. Larron. Okay, looks good. You can see the graft right here in the middle of the field. I just want to be sure about the position of the flap and the tympanic membrane and the graft, but it looks good. I just want to check this anterior part of the graft. Oh, all is good. Yeah, that's fine. Because it's important to check everything before leaving. But it looks good, and now I just make a final checking. I'm going to re-elevate the flap for the last time, and then you can see that the prosthesis stays in good position, which is fine. Okay, so I've just repositioned the flap and then put a marrow cell in the ear canal. Allez-y. Allez-y. Okay, thanks very much for watching again. Hope you enjoyed this case, which was quite interesting, as I include also the preparation of the graft from the traders, which I think is interesting. Thanks very much again, and see you again. Bye-bye.